Good morning, everyone. We shall talk about today's other part of the infectious disease. That is, we shall start with the diseases caused by the virus. Now, viral diseases are the most common cause of human illness. Many of the viral infections remain asymptomatic while others produce viral diseases. Another peculiar feature of the viral infection is that a single etiologic agent may produce various diseases in the same host depending upon the host immune response and at the age of infection. For example, varicella zoster virus is causative for chickenpox as well as herpes zoster. Viruses are essentially intracellular parasites. Depending upon their nucleic acid genomic composition, they may be single-stranded or double-stranded RNA or DNA viruses. This is a small table which shows the various diseases along with their etiologic agent like viral hemorrhagic fevers by the arthropod-borne viruses, influenza swine flu by influenza virus type A, viral encephalitis by arthropod-borne viruses, rabies by rabies virus or arbovirus, poliomyelitis or poliovirus, smallpox, variola virus, chickenpox, varicella zoster virus, herpes simplex and herpes genitalis like herpes, etc. Some other important diseases are also there like measles, rubella by the measles virus, rubella by rubella virus, mumps and various viral respiratory infections caused by adenovirus, echovirus, rhinovirus, etc. and gastroenteritis also by the rotavirus or Norway like viruses. We shall talk about viral hemorrhagic fevers now. These are a group of acute viral infections that have a common features of causing hemorrhages, shock and sometimes death. These viruses causing the hemorrhagic fevers were earlier known as arthropod-borne the virus since their transmission to humans were considered to be from arthropods. They are divided into four groups on the basis of the routes of transmission and other epidemiologic features. Number 1, mosquito-borne, like example of yellow fever, dengue, Rift Valley fever. Number 2, tick-borne, the Crimean hemorrhagic fever, Gynecological forest disease, zoonotic like Korean hemorrhagic fever, Lassa fever, Marburg virus disease and Ebola virus disease by unknown route. Out of all these mosquito-borne viral hemorrhagic fevers are in which the Aedes aegypti mosquitoes are the vectors are the most common over all world and especially in the developing countries. Two common examples of Aedes mosquito-borne viral hemorrhagic fevers are yellow fever and dengue fever. Now coming to yellow fever, it is also the oldest known viral hemorrhagic fever restricted to some regions of Africa and South America. Monkeys carry the virus without suffering from illness and the virus is transmitted from them to humans by Aedes aegypti as the vector. It is characterized by the following clinical features like sudden onset of the high fever, chills, myalgia, headache, jaundice, hepatic failure, renal failure, bleeding disorders and hypotension. Coming to the morphologic features, in the liver, mid-zonal necrosis, councilman bodies and the microvascular fat is seen. Changes are seen. In kidneys, the kidneys show coagulative necrosis of proximal tubules, accumulation of fat in the tubular epithelium and hemorrhages are seen. Patients tend to recover without sequelae and the death rate is less than 5%. Coming to the next entity, that is the dengue hemorrhagic fever. It is derived from the African word dengue, which means fever with hemorrhages. It is caused by virus transmitted by bites of mosquito Aedes aegypti and it is seen during highest after the and during the rainy season when mosquitoes are numerous. It was first described in 1953 when it struck Philippines. Since 1996, the cases have been seen every year in North India in post-monsoon rain period. Coming to next part, that is where it can be seen into two forms. Number 1, that is dengue fever or break-bone fever. It is an uncomplicated way in which self-limited febrile illness affecting the muscles and joints with severe back pain due to myalgia. Hence, it is given the name of the break-bone fever. Then the second form, that is the dengue hemorrhagic fever, which is the severe form and it is potentially fatal of Acute febrile illness characterized by cutaneous and intestinal hemorrhages due to thrombocytopenia, hemoconcentration, hypovolemic shock, and neurologic disturbances. It is most common in children under 15 years of age. There are 4 types of dengue viruses and all of them produce similar clinical syndrome. These viruses infect blood monocytes, lymphocytes, and endothelial cells. This initiates the complement activation and consumptive coagulopathy, including the thrombocytopenia. It takes place rapidly and may evolve over the period of few hours. If the patient is treated appropriately at this stage, there is rapid and dramatic recovery. But in untreated cases, dengue shock syndrome, which is very important, develops and the death occurs. Coming to few morphologic features, that is the predominant organ and changes in various organs in the dengue hemorrhagic fever. Focal hemorrhages and congestion will be present. Increased vascular permeability, which will result in edema in various organs. Coagulopathy with thrombocytopenia. Hemoconcentration. Now, the diagnosis of dengue hemorrhagic fever are confirmed by the following tests like serologic testing for the detection of antibodies, detection of virus by immunofluorescence method and monoclonal antibodies, rapid methods such as reverse transcriptase, that is PCR, polymerase chain reaction, and fluorogenic ELISA. The main abnormalities in investigations are like leukopenia with relative lymphocytosis, sometimes with atypical lymphocytes. Then thrombocytopenia, elevated hematocrit due to hemoconcentration, X-ray which shows bilateral pleural effusion, deranged liver function test where there will be elevated transaminases, hypoalbuminemia, and reversed albumin globulin ratio. Prolonged coagulation test, that which includes the prothrombin time, activated partial thromboplastin time, and thrombin time. At autopsy, the predominant organ changes which can be seen are in the brain, intracranial hemorrhages, cerebral edema, and dengue encephalitis will be seen. In liver, and it will be enlarged, and necrosis of the hepatocytes and Kupffer cells, Ray's syndrome in children will be present. The kidneys, petechial hemorrhages, and features of renal failure will be seen. Muscles and joints, perivascular mononuclear self-infiltrate will be seen. Now coming to the next entity, that is the chikungunya virus infection, which means that bends up, and it is derived from a language in Africa where the viral disease was first found in humans. It is a primarily infection in non-human primates, but the infection is transmitted to humans by Aedes aegypti mosquito. Clinically, the disease is characterized by abrupt onset of fever, severe arthralgia, which is producing a bending posture of the patient due to pain, and hence the name bending is given, and migratory polyarthritis, which affects the small joints, chills, headache, anorexia, nausea, abdominal pain, rash, petechiae, and ocular symptoms such as photophobia are seen. Some major laboratory findings include leukopenia, mild thrombocytopenia, elevated transaminase, and a Ray CRP are seen. Coming to the influenza virus infections, it is an important and common form of communicable disease, and it is prevalent as a seasonal infection in the developed countries. It is usually presented as like a mild afebrile illness similar to common cold by appearance of sudden fever, headache, myalgia, malaise, chills, and respiratory tract manifestations such as a cough, sore throat, or to a more severe form of acute respiratory illness and lymphadenopathy. Various forms of influenza virus infections have occurred as an outbreak at different cities and with the alarming morbidity and mortality in the world. Seasonal flu vaccine is administered to a population in high-risk countries in the developed countries. Coming to the etiologic agent, it is a single-stranded RNA virus belonging to coronaviruses. Depending upon its antigenic characteristics of the nucleoprotein and matrix, 3 distinct types are seen, A, B, and C. Out of this, influenza type A is responsible for most serious and severe forms of outbreaks in the human beings, while B and C causes the milder form of illness. Type A influenza virus is further subtyped on its based on its two viral surface features. Hemagglutinin H antigen elicits the host immune response by antibodies and determines the future protection against the influenza A virus. There are 16 distinct subtypes of type A. Neuraminidase antibody response against the N antigen limits the spread of viral infection, and it is responsible for the reduction of the infection. An antigen of the influenza A exists in 9 subtypes. Thus, the subtypes of influenza A viruses are designated by the denoting serial subtype numbers of H and N antigens like H1N1, H2N2, etc. They can also affect human beings, birds, pigs, and horses. In the view of high antigenic variation in H and N components, influenza A viruses are responsible for many known epidemics and pandemics in the history and in the present time. Major antigenic variation in H and N antigens is known as antigenic shift, while the minor variation is termed as the antigenic drift. And these are very important, both of them, antigenic shift and antigenic drift. In general, the population at high risk are immunocompromised usually, and they are elderly individuals and infants. Two of the most known common subtypes of influenza A viruses which have affected the human beings in recent times are under avian influenza virus A, H5N1, known as bird flu. Swine influenza virus H1N1 was also seen, which is commonly known as swine flu. Now coming to bird flu or influenza H5N1, influenza A. H5N1 subtype of the influenza type A virus infection causes severe acute respiratory syndrome, that is SARS, which is a common human form of the bird flu or the avian influenza with similar symptoms. There have been many outbreaks in the poultry birds in different parts of the world, which results in the slaughtering of millions of infected chickens every year. Human outbreak was seen, which was known as SARS, in December 2003 in China, Hong Kong, Vietnam, and it has spread to Asia, Europe, and America. Its rapid downhill and fatal clinical course and an apprehension of pandemic has sent alarm bells to all over the world for quarantine. Coming to pathogenesis, SARS is caused by influenza type A H5N1 respiratory virus, also known as SARS-associated coronavirus. Though it's not fatal for wild birds, it can kill poultry birds and humans acquire the infection through contaminated nasal, respiratory, and fecal material from the infected birds. An individual who has a human flu and can get infected with the bird flu, then the hybrid virus so produced is highly contagious and causes lethal disease. No person-to-person transmission has been reported, but epidemiologists do fear that if it will occur, it will be a global epidemic. Coming to the laboratory diagnosis, these abnormalities will be seen in the lab test, like almost normal to low total leukocyte count will be seen with lymphopenia in about half the cases, and mostly due to the fall in CD4 plus T cells. Thrombocytopenia, elevated liver enzymes, virus isolation by the reverse transcriptase PCR on respiratory sample, plasma, urine or stool, tissue culture, detection of the serum antibodies by ELISA or immunofluorescence. Clinical pathological features, normally this disease will begin with the influenza-like features such as fever, cough, dyspnea, sore throat, muscle ache, and eye infection. Then they will develop into viral pneumonia, which will be very evident on the X-ray chest, and acute respiratory distress will be seen, and it will form terminally kidney failure. There is an apprehension of epidemic of SARS if the avian virus mutates and gain the ability to cause the person-to-person infection. Currently, the vaccine is yet to be developed, and such available measures are directed at the prevention of the infection such as culling, that is the killing of the infected poultry birds and isolation of the infected cases. Now coming to swine flu or influenza A H1N1. H1N1 influenza virus type 1 and type A flu has appeared last in 1997 as a mild form of pandemic and is an outbreak in Mexico. This disease has already spread to 39 countries including US. Pathogenesis: it is a H1N1 influenza type A virus is primarily an infection in pigs with low mortality in them. The human beings acquire infection by direct contact with infected pigs. However, further transmission of H1N1 flu occurs by person to person contact such as coughing, sneezing, etc., but it is not known to occur from eating pork. Coming to clinical features, we have an unusual flu-like clinical features, but additionally, 1/3 of the cases are found to have diarrhea and vomiting. Human beings do not have any immune protection by antibody response against H1N1 influenza type A, and usual seasonal flu vaccine does not provide protection also. Personal hygiene and prophylaxis remain the mainstay for the further spread of the disease. Coming to varicella zoster virus infection, it is a member of the herpes virus family and causes chickenpox, varicella in non-immune individuals and herpes zoster shingles in those who had chickenpox in the past. Varicella or chickenpox, it is an acute vesicular exanthem occurring in non-immune persons, especially in children. It begins as an infection of the nasopharynx. On entering the bloodstream, viremia is accompanied by an onset of fever, malaise and anorexia. Maculopapular skin rash will usually appear on the trunk, face and the upper trunk and face in a day or two, which is then followed by formation of vesicles which rupture and heal with the formation of the scabs. A few cases may develop complications which may include pneumonia, hepatitis, encephalitis, carditis, orchitis, arthritis and hemorrhages. Herpes zoster or shingles. It is a recurrent painful vesicular eruption caused by a reactivation of dormant varicella zoster virus in an individual who had chickenpox in earlier years. The condition is infectious and spreads to children. The virus during a latent period resides in the dorsal root, spinal ganglia or in the cranial nerve ganglia. On reactivation, the virus spreads from the ganglia to the sensory nerves and to the peripheral nerves. Unlike the chickenpox, the vesicles in the shingles are seen in one or more sensory dermatomes and along with the peripheral nerves. These lesions are particularly painful as compared to the painless eruptions in the chickenpox. Coming to herpes simplex virus infection, there are two types, HSV type 1 and 2, which cause the fever blisters and herpes genitalicis respectively. HSV1 causes vesicular lesions on the lips, skin and mucous membranes. It spreads by close contact. It is usually severe in the immunodeficient patients and neonates, while the milder attacks of the infection causes fever, blister on the lips, oral mucosa and skin. Severe cases have shown complications like meningoencephalitis and keratoconjunctivitis. Various stimuli like the fever, stress and respiratory infection reactivate latent virus lying in the ganglia and result in acute attacks of the blisters. HSV2, it causes herpes genitalis, which is characterized by vesicular and necrotizing lesions on the cervix, vagina and vulva. Like HSV1 infection, lesions caused by HSV2 are recurrent and develop in non-immune individuals. Latency of the HSV2 infection is similar to HSV1 and organisms are reactivated by stimuli such as menstruation and sexual intercourse. Coming to rabies. It is a fatal form of encephalitis in humans caused by rabies virus. It is transmitted into the human body by the bite of infected carnivores like dog, wolf, fox and bats. The virus spreads from the contaminated saliva of these animals. Then it enters the peripheral nerve and travels to the spinal cord and brain. A latent period of 10 days to 3 months may elapse between the bite and the onset of the symptoms. Since the virus localizes at the brainstem, it produces classical symptoms of difficulty in swallowing and painful spasm of the throat termed as hydrophobia. Such other clinical features such as irritability, seizure, and the delirium points towards the viral encephalopathy. Death occurs within a period of few weeks. Coming to microscope features, microscopic feature shows the neurons of the brainstem with a characteristic Negri bodies which are intracytoplasmic, deep eosinophilic inclusions. Coming to the human immunodeficiency virus HIV, AIDS is caused by RNA virus, which called by the human immunodeficiency virus. There are 4 members of the human retrovirus in 2 groups. Transforming virus, they are the human T cell leukemia lymphoma virus, and 1 and 2 and are implicated in leukemia and lymphoma. Cytopathic virus, which includes HIV 1 and 2, causing 2 forms of AIDS. Most common type of AIDS in the world, including US, is HIV-1, while HIV-2 is etiologic agent for AIDS in the West Africa and other parts of India. Both HIV-1 and HIV-2 are zoonotic infections and their origin can be traced to the species of the chimpanzees, who are natural reservoir of HIV and are most likely source of the original infection. This is a schematic representation of the HIV virion or the virus particle. It is a spherical in shape and 100 to 140 nanometer. This particle has a core containing proteins. This is the RNA. This is the lipid membrane. Then there is a involvement of the enzyme called reverse transcriptase. This is a bilayered lipid membrane is seen with 2 viral glycoproteins, that is GP120 and GP41. These 2 are the viral glycoproteins. So coming to the little bit elaboration, it contains a core having core proteins, chiefly P24 and P18, 2 strands of genomic RNA and enzyme reverse transcriptase. The core is covered by a double layer of lipid membrane derived from the outer membrane of the infected host during the budding process of the virus. The membrane is studded with 2 envelopes of glycoproteins, GP120 and GP41. Besides the genes, 3 important gene codes for the respective components of virion are there. GHE, that is group antigen for the core proteins, POL, that is the polymerase for the reverse transcriptase, and ENV, that is the envelope for the envelope proteins. These genes and viral components act as markers for the laboratory diagnosis for the HIV infections. Remember these 3: GHG, POL and ENV. Coming to the routes of transmission, sexual transmission via blood and blood products, perinatal transmission, occupational transmission by other body fluids. This is a small pathogenesis. The pathogenesis of HIV is largely related to the depletion of the CD4 T cells, helper T cells, which results in profound immunosuppression. Here is a it is a pathogenesis of the HIV infection. And there is selective tropism for the CD4 molecule receptor. Then there will be internalization into it. Then there will be uncoating and viral DNA formation, and then viral integration will be there. Then we can see that they have split and they have replicated here, all of them. Okay, the last photograph which shows the replication. Then this is the replication, see. Then after that the immune attack will be there on the host cell itself. Since there was a depletion of the CD and T cells, T helper cells, there will be breakage of the host cell and the viral dissemination will be seen. Remember this pathogenesis, okay? Now coming to the impact of HIV infection on other human immune cells. HIV infects other cells on the host immune system and also affects the non-infected lymphoid cells. HIV infection of the nervous system. Out of the non-lymphoid organ involvement, HIV infection of the nervous system is the most serious, and 75 to 90% of the AIDS patient may demonstrate some form of neurological involvement at autopsy. It infects microglial cells, astrocytes, and oligodendrocytes. These are some major abnormalities seen in AIDS in the immune system basically. So it has been classified into 4 T cell abnormalities, B cell abnormalities, natural killer cell abnormalities, and monocyte macrophage cell abnormalities. T cell abnormalities, lymphopenia, CD4 cell depletion, CD8 cell lymphocytosis, reversal of CD4 is to CD8 cell ratio, and decreased antibody dependent cellular cytotoxicity. B cell abnormality shows no direct viral damage, but there will be some decrease in IG, immunoglobulin production, polyclonal activation, and all, etc. Natural killer cells has no direct viral damage, but there will be depressed number and decreased cytotoxicity. In monocyte macrophage cell abnormalities, there will be decreased chemotaxis and decreased cytotoxicity. This is a natural history and revised HIV classification. Phases like early acute, middle chronic, and final crisis. Period: early acute will be within 3 to 6 weeks, middle will be 10 to 12 years, and final is up to the period of death. The clinical category 1, asymptomatic infection, acute HIV infection. Category B, in the middle and the chronic, it is the symptomatic, neither A or nor C, but it is a condition secondary to the impaired problem. Okay. Then final one, there is AIDS indicating the defining conditions. Here these are various cell categories. These are the values, like more than 500, 200 to 400, or less than 200. These are some pathological lesions and clinical manifestations. These are major clinical manifestations like wasting syndrome, persistent generalized lymphadenopathy, gastrointestinal manifestations, pulmonary manifestations, mucocutaneous manifestations, hematologic, CNS, gynecologic, renal, hepatobiliary, cardiovascular, ophthalmic, musculoskeletal, endocrine. Almost all the systems are affected. In the secondary opportunistic diseases, fungal, viral, bacterial, protozoal, and helminthic causes will be there, okay, which will also give an immunocompromised state to the person. Coming to the secondary neoplasms are there: Kaposi's sarcoma, primary CNS lymphoma, non-Hodgkin's lymphoma, and Hodgkin's lymphoma, HPV associated carcinomas, bacillary angiomatosis. Neurologic diseases like AIDS, dementia complex, meningoencephalitis, aseptic meningitis, peripheral neuropathy, lymphoma, etc. Now this is the most important for the AIDS. That's the test for the diagnosis. Test for establishing HIV infection like antibody test like ELISA, Western blot. Direct detection can be seen by P24 antigen capture assay, HIV RNA assay, PCR, then culture of HIV. Second comes the test for the defects in the immunity like CD4 T cell count fall and CD8 T cell count increase. The ratio will be reversed. The lymphopenia will be there. Hypergammaglobulinemia will be seen. Increased beta 2 microglobulin levels. Platelet count will show as thrombocytopenia. Then comes the test for the detection of the opportunistic infections and the secondary tumors by the FNAC or exfoliative cytology and by biopsy. Now we shall talk about each of them in short. In antibody test, ELISA's initial screening is done by the serologic test for antibodies by enzyme linked immunoabsorbent, that is the ELISA, against GAG and ENV proteins. This is the most important thing. What is the main involvement is of the GAG and the ENV proteins. The term endo period is used for initial 2 to 4 weeks period where the patient are infectious but the screening test is negative. But while seroconversion is a term used for the appearance of the antibodies. Besides, ELISA can be false positive in autoantibodies, liver disease, recent vaccination against flu, and other viral infections. Western blot, like if ELISA is positive, confirmation can be done by Western blot by the presence of specific antibodies against all three HIV antigens like GAG, POL, and ENV. Now coming to the direct detection, P24 antigen capture assay, then DNA PCR by amplification of the proviral DNA, HIV RNA assay methods by reverse transcriptase method, branch DNA, nucleic acid sequencing amplification can be seen, and culture of the HIV from the blood monocytes and CD4 plus T cells can be seen. Test for the defects in the immunity like CD4 T cell counts, progressive fall can be seen. CD8 T cells can be seen in increased number. Reversal of the ratio of the CD4 and CD8 is seen, and lymphopenia will be present. Polyclonal hypergammaglobulinemia will be seen. Increased to alpha microglobulin will be seen. Platelet count shows thrombocytopenia. Test for the opportunistic infections, as we said before, is by biopsy or FNAC. Now we shall come to the next entity, that is the diseases caused by the parasites. Diseases caused by parasites, that is protozoa and helminth, are quite common and comprise a very large group of infestations and infections in human beings. Parasites may cause diseases due to their presence in the lumen of the intestine, due to the infiltration in the bloodstream, or due to the presence inside the cells. This is a table which shows the various diseases caused by the various parasites, like the protozoal and helminthic. In the protozoal comes the Chagas disease by Trypanosoma cruzi, Leishmaniasis by Leishman tropica, Braziliensis and Donovani, malaria by Plasmodium vivax, Falciparum ovale and malady, then toxoplasmosis, pneumocystosis and amoebiasis and giardiasis. Then comes the helminthic diseases like Escherichiasis, enterobiosis, hookworm, trichinosis, filariasis, visceral larva migrans, cutaneous larva migrans, schistosomiasis, fasciocoliasis and echinococcosis, cystosarcosis. Coming to amoebiosis, it is caused by entamoeba histolytica, named for its lytic action on its tissues. It is the most common intestinal infection of man. It is more common in tropical and subtropical areas with poor sanitation. The parasite can be seen in two forms: trophozoite form, which is like the active adult form seen in the tissues and diarrheal stools, and a cystic form can be seen in the form stools but not in the tissues. This can be stained positively with PAS stain in tissue sections, while the amoebic cysts have 4 nuclei and can be identified in the stools. The cysts are the infective stage of the parasite and can be found in the contaminated water or food. The trophozoites are formed from the cyst areas in the intestine and colonize in the cecum and the large bowel. The trophozoites as well as the cysts are passed out in stools, but the trophozoites fail to survive outside or are destroyed by the gastric secretions. Coming to few morphologic features, the lesions include amoebic colitis, amoeboma, amoebic liver abscess, and it spreads to the various other sites. Amoebic colitis, it's the most common type of of amoebic infection. It begins as a small area of necrosis of mucosa which may ulcerate. Then they will get enlarged and develop undermining of the margins of the ulcer due to the lytic action of the trophozoite and have a necrotic bed. Such chronic amoebic ulcers are described as flask-shaped ulcers due to their shape. Remember this, flask-shaped ulcers. The margin of the ulcer shows inflammatory response consisting of the admixture of the polymorphonuclear as well as mononuclear cells beside the presence of trophozoites of entamoeba histolytica. This photomicrograph shows for the amoebic colitis. This section shows amoebic ulcer due to the necrotic debris, acute inflammatory infiltrates and few trophozoites and entamoeba histolytica, which is shown by the arrows. Amoeboma. It is a inflammatory thickening of the wall of the large intestine resembling the carcinoma of the colon. Microscopically, it shows inflammatory granulation tissue, fibrosis and clusters of trophozoites at the margin of necrotic with viable tissue. Amoebic liver diseases may be formed by the invasion of the radicle of the portal vein by trophozoites. Amoebic liver abscess may be single or multiple. These abscesses may contain yellowish grey amorphous liquid material which the trophozoites are identified at the junction at the viable and necrotic tissue. Some other sites of are peritonitis by the perforation of the amoebic ulcer of the colon, extension to the lungs and pleura by the rupture of the amoebic liver abscess, hematogenous spread to cause the amoebic carditis and cerebral lesions, cutaneous amoebiasis, and by the spread of rectal amoebiasis or from anal intercourse. This photograph shows the various organs involved: brain abscess, lung abscess, subdiaphragmatic abscess, liver abscess, amoebic colon ulcers in the colon, periappendiceal abscess, and amoeboma colon. Now we shall talk about the next disease, that is the malaria. It is caused by one or combination of any of the four species of plasmodia, that is Plasmodium vivax, Plasmodium falciparum, Plasmodium ovale, and Plasmodium malariae. Plasmodium falciparum causes the malignant malaria, while the other three species are benign form of the illness. These parasites are transmitted by bite of female Anopheles mosquito, and it is endemic in various parts of the world, especially in the tropical Africa, parts of South and Central America, India, and Southeast Asia. This is a life cycle. Okay, read about it. In human, it will affect in the brain as encephalopathy. In heart, it will show as the congestive heart failure. Liver as hepatomegaly, spleen as splenomegaly, and kidneys as hemoglobinuric nephrosis. The Plasmodium falciparum differs from the others because it does not have an exoerythrocytic stage. Erythrocytes at any age are parasitized, while the other plasmodia parasite juvenile red cells. One red cell may contain more than one parasite. The parasitized red cells are sticky, causing obstruction in the small vessels by a thrombi, and a feature which is responsible for the extraordinary virulence of the Plasmodium falciparum. The main clinical features of the malaria are cyclic peaks of high-grade fever and accompanied by the chills, anemia, and splenomegaly. Coming to the morphologic features, parasitization and destruction of the erythrocytes are responsible for the major pathologic changes. Number 1, the malarial pigment liberated by the destroyed red cells accumulates in the phagocytic cells in the reticuloendothelial system, and it causes the enlargement of the spleen and the liver. This causes the hepatosplenomegaly. In falciparum malaria, there is massive absorption of hemoglobin by the renal tubules, causes the black water fever or hemoglobinuric nephrosis. At autopsy, cerebral malaria is characterized by congestion and petechiae on the white matter. Parasitized erythrocytes in falciparum malaria are sticky and gets attached to the endothelial cells, resulting in the obstruction of the capillaries of the deep organs such as the brain, leading to hypoxia and death. If the patient lives, microhemorrhages and microinfarcts can be seen in the brain. Major complications which can be seen are cerebral malaria that causes coma, hypoglycemia, renal impairment, severe anemia, hemoglobinuria, jaundice, pulmonary edema, and acidosis, followed by congestive heart failure and hypotensive shock. This is a diagnosis of malaria seen in the by demonstration of the thick and the thin blood flames, and sometimes in histologic sections also. Here we can see the ring stage of the Plasmodium vivax, and here is the amoeboid view. Here is again the ring forms of the other Plasmodium falciparum, or these are Plasmodium falciparum ring stage. These are gametocytes of Plasmodium falciparum. Now coming to filariasis, Wusteria bancrofti and Brugueria malayi are responsible for causing the Bancroftian and Malayan filariasis in different geographic regions. The lymphatic vessels inhabit the adult worm, especially in the lymph nodes, testes, and epididymis. Microfilariae can be seen in the circulation and are produced by the female worm. Majority of the infected patients remain asymptomatic. The symptomatically they have two forms of the disease, acute and chronic. Acute form where there can be presented as with fever, lymphangitis, lymphadenitis, epididymoorchitis, urticaria, eosinophilia, and microphilaramia. Chronic form of the filariasis is seen by the lymphadenopathy, lymphedema, hydrocele, and elephantiasis. This microphotograph shows a microfilary in the peripheral blood smear. Coming to morphological features, the most significant histologic changes are due to presence of adult worms in the lymphatic vessels, causing lymphatic obstructions and lymphedema. The regional lymph nodes are enlarged and their sinuses are distended with lymph. The surrounding tissues are blocked. The lymphatics are infiltrated by chronic inflammatory infiltrates, which consist of lymphocytes, histiocytes, plasma cells, and eosinophils. Chronicity of the process causing the enormous thickening and enduration of the skin of the legs and the scrotum resembling the hide of an elephant, and hence the name elephantiasis. Chylous ascites and chyluria may occur due to the rupture of the abdominal lymphatics. Coming to the next disease, that is cysticercosis. It is an infection by the larval stage of Taenia solium, the pork tapeworm. The adult tapeworm resides in the human intestines. The eggs are passed in the human feces, which are ingested by pigs, or they infect the vegetables. These eggs then develop into larval stages in the host, spread by the blood to any site in the body, and form the cystic larvae termed as cysticercus cellulosae. Human beings may acquire the infection by the larval state by eating undercooked pork. There's the measly pork by ingesting undercooked contaminated vegetables, and sometimes auto-infection also. Coming to the morphologic features, the cysticercus may be single or may be multiple cysticerci in the various tissues of the body. The cysts are occurring virtually anywhere in the body and accordingly produces symptoms like in the brain, musculoskeletal system, and skin. Cysticercus consists of a round to oval white cyst in about 1 centimeter in diameter and contains milky fluid and invaginated scolex with bifringent hooklets. Then the cysticercus may remain viable for a long time, and there might be no inflammation. But when the embryo dies, it produces granulomatous reaction with eosinophils. Later, the lesion may become scarred and calcified. In this photograph, we can see various numerous cysticerci in the base of the brain. This is a cysticercus in the skeletal muscle. This is the body of the parasite. This is the coelomic cavity, and this is the cuticle. The worm is seen in the cyst, while the cyst wall shows palisading. Now coming to torch complex. The acronym TORCH refers to the development of various complex of symptoms in infants due to the infection with various microorganisms, which include toxoplasma others, rubella, cytomegalovirus, and herpes simplex virus. Category of others refers to the infections such as hepatitis B, Coxsackie virus B, mumps, and poliovirus. The infection may be acquired by the fetus during the uterine life or perinatally and damage the fetus or the infant. Since the symptoms produced by the TORCH group of organisms are indistinguishable from each other, it is a common practice to test them for one main TORCH agent in a suspected pregnant lady or infant. It has been estimated that TORCH complex infections have overall incidence of 15% of all live-born children. They are transmitted transplacentally and therefore infect the fetus from the mother. Herpes and cytomegalovirus infections are commonly intrapartum infections and produced venereally, acquired venereally. Toxoplasmosis is a protozoal function acquired by contact and by cat species or by ingesting the raw uncooked meat. Rubella or German measles is teratogenic in pregnant mothers. Cytomegalovirus and herpes virus infections are generally transmitted to fetus by chronic carrier mothers. An infectious mononucleosis like disease is present in about 10% of the mothers whose infant have toxoplasma infection. Genital herpes infection is present in 20% of the mothers whose newborn babies suffer from herpes infection. Rubella infection during the acute stage in the first 10 weeks of the pregnancy is more harmful to the fetus than at the later stage of gestation. Symptoms of the cytomegalovirus infection are present in less than 1% of the mothers who display antibodies to it. The classic features of the syndrome produced by TORCH complex are seen in congenital rubella, and the features included are ocular defects, cardiac defects, CNS defects, sensory neural deafness, thrombocytopenia, and hepatosplenomegaly. The fetal damage caused by the TORCH complex infections is irreparable, and therefore prevention and immunization are the best modes of therapy. In this photograph, we can see the various syndromes which are showing the various features like microcephaly, microphthalmia, pneumonitis, jaundice, heart diseases, splenomegaly, hepatomegaly, petechiae and purpura. Thank you for today.